Good afternoon. Trauma, evidence, experienced or witnessed event that poses real or perceived threat to either yourself or someone close to you. How often does trauma occur? Statistics show us that before reaching age of 16, it's estimated that 2/3, 66% of children in the United States have experienced a traumatic life event. What does that mean for us in North Dakota? 1 in 10 children are estimated to have experienced child sexual abuse by 18. 2017 data show us that almost 4,000 referrals for child abuse and neglect occurred in North Dakota. A brief in 2016 looked at adverse childhood experiences and that prevalence in children. Pam talked about earlier adverse childhood experiences. Events like physical abuse, sexual abuse, emotional neglect, physical neglect, having a caregiver incarcerated, having a caregiver with mental health difficulties, having a caregiver with substance use difficulties, having caregivers split, separated. This data shows us that in North Dakota, for children from birth to 17, about 40% have at least one adverse childhood experience. So that's not all trauma, just those 10 events that I talked about. And the bottom line of this is that high rates of trauma exposure is the reality. We're not talking about a small percentage of children. We're talking about a pretty large percentage of children that are experiencing adversity and trauma. This is a public health concern. And the reason it is because there are many ways that adversity and trauma impact development and functioning. We have to do something to change the trajectory of children's lives. There are so many children impacted by trauma and adversity, and we have to do something to change that. The ACEs study, done in the 90s, biggest study of its kind, 17,000 adults, looking at what is the relationship between trauma, adversity, and health in adulthood. And what they found was there's a pretty strong relationship. The more adversity that you experience in childhood, the more likely you are to have physical, behavioral health difficulties, problems. Higher rates of suicide, higher rates of heart disease, higher rates of incarceration, substance use difficulties, mental health problems. And what this was showing us is that there is evidence to show that trauma affects individuals in multiple ways, in the way they develop, in the way they function. The ACEs study, this is the hypothesis from that data. And when we look at it, what it's saying is that when you experience adverse childhood experiences, that in turn disrupts your neurodevelopment at a biological level. Your brain changes. And when your brain changes, your social, emotional, and cognitive functioning changes. And when that changes, you're more likely to adopt health risk behaviors. And when you adopt health risk behaviors, you're more likely to experience disease, disability, and social problems. And when you're experiencing disease, disability, and social problems, you're more likely to be dying earlier, just like Pam said earlier today. Now, when I look at this pyramid, I sometimes get really like, this is really morbid, there's no hope, what are we supposed to do? And I have to reframe, right? Because when we know what's predictable, we know what's we know how to prevent things. We know it's preventable, okay? So if this is the possible outcome, how do we change that trajectory? And there's been a lot of development since this study came out in looking at how trauma affects children and adults. And there's a lot of talk and presentations on what's your ACE score, okay? And I want to remember that the development from the 90s to now is great. We have trauma treatment, evidence-based treatment for children and adults that helps change the trajectory. And that is very important. It doesn't have to go this way. We don't have to experience adversity and lead to early death. People that experience adversity can be well-adjusted, high-functioning, successful, hopeful about life. When we don't do early intervention, this is what it looks like. You experience trauma in childhood, there's that biological change, which in turn does behavioral change, family change, and social change. When those all occur, you've got a post-traumatic stress reaction. And the reality, when we don't do early intervention, is that there's a long passage of time between when that traumatic stress reaction occurs and when intervention occurs. As talked about earlier, that onset of symptoms to intervention varies depending on diagnosis, but the average is 8 to 10 years. Now, a lot happens in 8 to 10 years. That PTSD develops into more severe symptoms. Major depressive disorder, substance use disorder, and you've got a lot of comorbidity. And by the time the person presents for treatment, you're not looking at the trauma, you're looking at the depression, the substance use disorder, and you're treating those things. And unfortunately, they're connected. So people aren't getting better because we're treating the thing that we see right now, not maybe the original cause. So this vicious cycle develops. Unidentified, untreated PTSD is linked to a variety of psychiatric disorders: depression, anxiety, substance use, eating disorders, personality disorders. And this relationship perpetuates each other. The dysregulation in PTSD without treatment can develop into other psychological disorders, and they're perpetuating. It's a vicious cycle, okay? When we intervene early, we can change that cycle. We can change the trajectory. When you intervene early, you're intervening soon after that traumatic event. You're doing a trauma screen, identifying whether post-traumatic stress reactions are occurring, to be able to send that person to trauma assessment, to send that person to trauma treatment. So the way that this looks different is the person's actually getting treatment for the cause of the reaction, okay? And it's a shorter period of time. It's not 8 to 10 years. There's been a lot of work, as I said, in how do we respond to child trauma, adult trauma. And the National Child Traumatic Stress Network, NCTSN, it kind of guides us. How do we develop trauma-informed systems? And their guide is when you have a family service system that's trauma-informed, all parties recognize and respond to the impact of trauma. The programs and agencies within these systems infuse and sustain trauma awareness, knowledge, and skills in their organization, culture, practice, and policies. And they act in collaboration with all those involved to help the child and family recover and be resilient. Now, how do we do that, right? Okay, so they're very helpful and they give us these steps. And so the first one on the list is routinely screen for trauma exposure and related symptoms. Because when you screen, you can identify, and then you can refer for assessment and treatment, utilizing a culturally appropriate, evidence-based assessment and treatment, making sure that resources are available, engaging in efforts to strengthen resilience and protective factors of children and family, addressing parent and caregiver trauma and the impact on that family system, emphasizing continuity of care and collaboration across the child-serving system. And the last one, which is very important, okay, is remembering the impact of secondary traumatic stress and making sure the environment for staff addresses and minimizes that risk. So, how are we doing this in North Dakota, okay? There's been a lot of work. And I'm not going to talk about everything that's happened in the past and everything that's happening in the future. I'm going to talk about just a few things, okay? TCTY, the Treatment Collaborative for Traumatized Youth. That's kind of where I work in helping disseminate evidence-based treatment and trauma screening, helping systems develop trauma-informed approaches, and trying to raise the level of care for children and adults that have experienced trauma. Our mission is really to enhance availability of evidence-based trauma-specific mental health treatment for traumatized individuals in North Dakota, because we want to implement and evaluate evidence-based treatments and build a multidisciplinary collaborative network across our region. To do this, we train, we connect providers in the community, we want to support providers, and we want to evaluate treatments. Now, TCTY has been active since 2006, and we've done a lot of things, and as I said, I'm not going to go about telling you everything that's happened in the past because we want to look to the future, but there's been a lot of work through TCTY and a lot of other organizations to try and change the state approach to traumatized individuals. So where are we heading? After we've done all this work in the last few years, where are we heading now? In partnership with the state, Behavioral Health, North Dakota, we are working to provide providers with free training on evidence-based treatment, okay? So we're doing TFCBT, which is trauma-focused cognitive behavioral therapy, learning collaboratives. We talked about implementation science earlier just a little bit. So that's using implementation science to really implement and disseminate these treatments. We're working on trauma screening and child serving systems, and we're making sure that people in the community, providers, families, have access to who these providers are that can help their families and their children. So we're kind of going at it from a couple different directions. We're going at it a little bit in prevention, which I'm going to get to at the end. We're also going at it at the trauma screening. We're also going at the trauma assessment and the trauma treatment. We're trying to change the trajectory. So there's a lot of confusion sometimes about what is trauma screening, because we talk about assessment and screening and what is it and who does it. So NCTSN kind of defines trauma screening. It's done by frontline workers in child serving systems, sometimes mental health. You do not have to have a license in mental health to do this. You're trained in the measure. It's brief in length. It's got questions regarding child exposure and response to trauma. And it's done when caseworkers or frontline workers need to determine, does a child need further assessment? Are they needing further treatment? And it kind of helps facilitate that discussion. It is not a diagnosis, and it can be used when we know that a child is likely to have experienced trauma or we're concerned. TCTY is partnered with the University of Minnesota and the Institute for Translational Research and the AMBIT Network to use the traumatic stress screen for children and adolescents. That's developed by the U of M, and that's what we're training in. The TSSCA is 5 questions on trauma symptomology. It's to be used by frontline workers, child serving system, mental health. It's normed for children ages 5 to 18. It takes about 5 minutes to do. It's 1 page. And the purpose is to use it to determine whether further assessment and services is needed. It's got good psychometrics. It's been developed through research to determine what score predicts the need for treatment. So it's got a cutoff score, and then you would refer on. So we're doing trainings, interactive webinars, and in-person trainings for child serving system in this trauma screening tool. It's a tool to help individuals and child serving systems know, how do we help kids that we're concerned about, and how do we make sure that they get to the services that they need. TCTY is also doing the Learning Collaborative on trauma-focused cognitive behavioral therapy. And most of you have probably heard about TFCBT. It's the gold standard in trauma treatment for children. It has the most research behind it. It has a lot of random controlled trials, evidence for multiple types of trauma across different populations, national, international. It's for ages 3 to 18. It covers a variety of topics: psychoeducation on trauma and PTSD, parenting skills, coping strategies. It looks at the trauma narrative, the story of what happened, and how we do safety planning and communication with parents, caregivers. It's not just focused on the child. It has an element of the caregiver and the family. And why this is important is because where does the kid go after they leave the mental health session? Home, right? So we have to work with caregivers. And the research shows really good outcomes for TFCBT. Post-traumatic stress symptoms reduce, emotional symptoms reduce, behavioral symptoms reduce, parent trauma symptoms reduce. Parents can be traumatized by what happens to their kids, and that really impacts the family system. So this treatment has fantastic outcomes and can really help kids work through that trauma and continue to hope for the future and not get stuck and not have those depression symptoms worsen and turning to substance use and alcohol or eating disorders. So we're screening, we're identifying the kids, we have this treatment, how do we find the providers, right? So tcty-nd.org has a clinician roster of all the providers trained in North Dakota in evidence-based trauma treatments. There's been a lot of effort since TCTY was created to train mental health providers in North Dakota in TFCBT. Now, there are a lot of challenges. We have not got a TFCBT provider in every county in the whole state, so there are a lot of challenges, but we're continuing to work. We're continuing to provide that training and train and support. We also have resources on our webpage. It's accessible for both clinicians and families. So as we work to change this trajectory, TCTY is also working to build the network, to connect the providers, increase resources, and add new trainings. What about the providers that have been doing this work for a long time? They need more advanced training, so we need to be able to offer that as well. We need to fill the gaps in our behavioral health system. What aspects of trauma are not being addressed? What about the comorbidity of substance use and trauma? What treatment can we advocate for and train in that? What about the parents' symptoms when it's so severe that the parent maybe needs treatment? Now, as I said, there's a lot of challenges when it comes to disseminating treatment and then access to that treatment. North Dakota is 90% mental health shortage area, right? So how do we overcome this? Telehealth is really important in this area. And it's very exciting to me to see some of those advances. And the Medical University of South Carolina has done incredible work in examining and doing research on telehealth. There's been a lot of work showing the effectiveness of trauma treatment with adults. And then they have translated that to work on specific treatments for children and trauma. So they have done work on TFCBT via telehealth. And we were very lucky to have MUSC come to North Dakota and work with the CACs of North Dakota to train some providers in how to adapt TFCBT for telehealth so that your fidelity, your treatment is just as good and your barriers are reduced and more kids have access. And so this excites me because as we're doing more trauma screening trainings, last year I was getting questions like, well, where do we send the kids? I don't have any providers in my area. And now we can say there's a lot more access. So there's a lot of work to be done. TFCBT via telehealth has been researched by MUSC, and they're doing a lot of work on it, and there's still more work to be done. But this is an exciting development. Additionally, we're involved in a prevention campaign, so we're also trying to intervene with prevention. Stand to Protect is a child abuse, sexual abuse prevention campaign, and TCTY is assisting with kind of evaluating the program and that implementation science part of it. So we're trying to be involved in this trajectory at multiple stages. Hopefully prevention, and then early intervention with screening, teaching providers how do we do good trauma assessments, training providers in evidence-based treatment, and making sure that our community has access to who those providers are. So there's a lot going on by TCTY, other organizations. A lot of work is happening in child trauma, and there's still more to be done. And so I want to just pause for a moment for you to think about your organization and what steps maybe you've taken, and what steps are still needed. Becoming a trauma-informed system is not something you do in one day. Even systems that are doing the trauma work have to make sure that they're constantly reevaluating to make sure that they are a trauma-informed system. And so what do you have to do? How do you recognize and respond to the impact of traumatic stress in your organization, in your classroom, with your staff? How do you infuse and sustain trauma awareness, knowledge, and skills? Is it policy changes? Is it staff training? How do you facilitate and support recovery and resiliency of these children and families? So that's really what I want you to think about today. I hope that you're inspired, that there's a lot of work going on to make change, positive change, so we don't have to look at that pyramid and say we're going on the road to early death, that we're intervening early and we're reducing the impact of trauma. We're taking a stand. So it does take early intervention, it does take prevention, and it takes all organizations that have children come through their doors to stop and pause and say, how do we change our system? How do we help the kids that are hurting? How do we facilitate their recovery? How do we increase their resilience? So I hope that you can think about that and talk to your administrators, or if you're the administrator, think about it really hard. And here's our contact information. Some people, I see Jen here. Myself and then Miranda are kind of the main contact people for TCTY right now. If you have questions or are interested in trainings, we can kind of field that and figure out how to connect you and help you. We can't do it all. We all need to kind of come together and collaborate, but we are definitely open to helping figure out how to help your system help kids recover and be resilient in the face of adversity. Thank you very much.